Okay, welcome everyone to today's session.
Hello, everybody. Thank you for having us today. So I'll start off with the typical case of a 46-year-old unvaccinated man who has a history of obstructive sleep apnea, paroxysmal atrial fibrillation not on anticoagulation, and also mild obesity of BMI 32.6. So on day one, he developed non-productive cough, sore throat, and fatigue, seemingly mild. And he and his wife both tested positive for COVID-19 on that day. And he was doing okay until day 7, when he presented to a local emergency department with dyspnea, lightheadedness, chills, and fatigue. And on physical exam, he was febrile, had a pulse of about 95. He was tachypnic to about 36 breaths per minute, mildly hypertensive with a blood pressure of 145/88, and his oxygen saturation was about 88% on room air. His EKG was significant for sinus tachycardia in the 1-teens, and chest X-ray showed a 5.5 centimeter gas collection in the right lung apex, likely a pulmonary bulla, but loculated pneumothorax was also possible. So on that day, he was placed on supplemental oxygen. Next slide. So he was placed on supplemental oxygen via nasal cannula. He was started on IV dexamethasone, and he was instructed to self-prone about 12 to 16 hours per day. He was also placed on Lovenox 40 milligrams daily for DVT prophylaxis. He, however, refused initiation of remdesivir. His symptoms worsened on day 8. He was now requiring about 10 liters of oxygen. He was transferred to the ICU and placed on 100% high flow oxygen. And he also developed diarrhea and inability to smell on that day. He agreed to start remdesivir. So he was started on remdesivir plus baricitinib. And he initially had paroxysmal AFib, but now his atrial fibrillation worsened with a rapid ventricular response and was started on a standing dose of metoprolol 50 milligrams daily. So by day 12, his symptoms continued to worsen, and his oxygen saturation increased, and he needed to be intubated, and he was thus transferred to Mayo Clinic, Rochester, Minnesota, a tertiary medical center. On arrival, he was started on amiodarone for the persistent atrial fibrillation. He also became very hypotensive and required norepinephrine for pressor support. And of note, on day 11, labs from the local hospital showed he had a D-dimer of 511, but on arrival at Mayo Clinic, his D-dimer had gone up to 45,000. Ultrasound of the lower extremities were negative for DVT. He was too sick to undergo CT angiography to diagnose any PE. And so he was started on a full dose heparin for anticoagulation. And the remdesivir was stopped after 2 doses once he was on mechanical ventilation. So by day 14, he had developed acute kidney injury. Remember, baseline creatinine at max was about 1.12 milligram per deciliter, but by day 14, his creatinine had gone up to 5.2 milligram per deciliter, and his arterial blood gas showed a pH of 7.02 with a serum bicarbonate of 16 and an ion gap of 20. And he had received some IV fluids, and so his volume status was up to 10 liters positive. Urine output had unfortunately dropped to about 600 cc's per day, despite aggressive diuretics. He was getting about 360 milligrams of IV Lasix and 500 milligrams of diureal per day. And his hypotension worsened to the point of needing to be on 4 pressors that included norepinephrine, vasopressin, phenylephrine, and angiotensin II. His PF ratio also dropped to 58, which is suggestive of severe ARDS. And he was thus started on continuous renal replacement therapy with 32 millimole per liter of bicarbonate, and he also received IV